All right, good morning. Quick, um, quick announcement, especially for those interns following over Zoom. Just received a notice that we cannot live stream this until we update the latest version on Instagram. So first time I saw that message. So we are not live streaming. We're just on Zoom only this morning. So to kick us off, first thought, any particular character, any particular scene the group would like to begin?
Sure. So for this episode of Seinfeld, the suicide, I think when the episode was initially starting, what stood out to me was the description given by the girlfriend as to why her belief as to why Martin, attempted to commit suicide. And I found it, kind of interesting because thinking about all of the, mood disorders that he might fall under, a lot of the things that we think about often are like timeline. And you don't get much of a timeline given this because she just says, he tried to kill himself because he was upset, he got jealous. And so it seems like a very acute turn of events. We don't really get much context to how his mood or how he had been doing over the past few weeks or anything like that. So we kind of make a lot of assumptions or kind of have to strain to fit him into a certain diagnosis. So that was just something that stood out to me, how she would talk about Martin and what happened.
Yeah. So I think a couple of things to highlight here. Kind of building off what you just had mentioned and what you just had identified. Number one is, especially in situations like this, of course, there's a multitude of times where psychiatrists, other healthcare professionals are not going to get the full story from their patient. And it is incredibly important to talk to collaterals. And that's exactly what we see Larry David produce here, and especially that particular scene. And is it Maria? Gina.
Yeah.
Gina. Okay, so when Gina provides us the information that we would, fairly quickly inquire about, what we're told is that there was a moment of jealousy. Now we know that's not the full picture, and very quickly we might think back to our first year of medical school where we learn how to formulate behavior and therefore how to formulate and make sense of abnormal behavior, such as a suicide attempt. And even though we often talk about that being in a biopsychosocial context, and we could also consider a context within what is referred to as the 3 Ps. So what predisposes an individual to attempt suicide, what precipitates, and then what perpetuates that behavior. The precipitate looks like there was a moment of jealousy. But very quickly, and I think the way you worded it was, we have other questions to kind of fill in the gaps along those lines. And all that's telling me is that we may have identified the precipitant, but the rest of the story will be the predisposing elements to this. Was there a past psychiatric history significant for major depressive disorder, etc.? Right. So, and we won't know until we watch the prequel, which of course doesn't exist. Right. So the actual attempt and the information we have on the HPI is still missing that element of the past psychiatric history, which might include the predisposing biopsychosocial factors contributing to the suicide. So that's what I took from what your observation was. Anything else regarding either Gina or Martin? Did you like Gina?
No, she's kind of annoying.
So kudos. Often, and especially when people wear like short white coats, they say things that you think your professor wants you to say. And in psychiatry, through 4 years of training, one of our main objectives is to undo that type of thinking, those bad habits that your parents taught you about being nice, because you have to be honest. Because if you're not honest, you're not going to pick up on countertransference. And if you don't pick up on your countertransference, you are going to actually potentially do harm to your patient, and you're going to take an oath not to do that. So the idea that she annoyed you, and she annoyed all of us, was something that only was tapped into, at least the first person to say it. And we'll continue this conversation accordingly. Once you have that feeling, please don't dismiss it. All right, that's the bad habit our parents taught us, to dismiss those feelings. They're not right. In a clinical practice, not only are they right because they're honest, but they are often clinically helpful. Because at some point, and maybe not during the initial patient interview, maybe not immediately, but at some point you have to ask yourself, why? Because the answer 99 times out of 100 lies in what the patient is doing, not on you, right? And that's something now, I'm 25 words or less. Nobody's having an epiphany here. This is 4 years of education, right? This is 4 years of residency training in psychiatry. That said, anybody have any insight or speculation as to why an individual might have that type of countertransference towards Gina? What is she doing that pushed your subconscious internal buttons?
They seem to have some sort of underlying, motivation to, seeking like the attention or validation, I guess, of Jerry Seinfeld in a moment where her boyfriend was in a coma. And it seemed like a very, very fast change in attitude from her boyfriend to jumping to Jerry. So it was kind of confusing. You kind of felt like every time she would ask him questions, like kind of egging him on looking for a certain response. And it was like, I think that is what bothered me, at least, kind of trying to figure out like what is she trying to get out of this.
And there might be two scenarios here. One is that upon observing that, you had that countertransference develop. The other scenario is that you had the countertransference prior to, and the behavior that you see being her being flirtatious with someone when her fiance or husband is in a coma may have just reinforced and confirmed your suspicion, right? So it could happen on either level here, but in either case, there seems to be something going on with our patient. Again, it's not going to happen this quickly in therapy. Any speculation as to what's going on with Gina?
I think her behaviors might be a possibly like an acting out of some kind of tension going on with her current relationship with LinkedIn. Because that sudden turnaround to go flirt with another man just seems very odd, and I don't really think she was genuine in her efforts to win over Jerry Seinfeld. I think there was, like as I mentioned, some kind of not a coping behavior, but something that was bothering her in her current relationship that she's kind of trying to seek out maybe with Jerry. And I think that part of the reason why she prompted or she acted that way. And I'm also just watching her throughout the episode. I was just thinking, I know we didn't have any lectures on personality disorders yet, but like maybe a possible personality disorder just in terms of her promiscuity, maybe like a borderline histrionic, something like that.
Mm-hmm. And hypothetically, again, if we were now a sequel to this particular episode, one of the things we might inquire about are additional signs and symptoms defining really a general personality disorder, and then if screening positive, a specific personality disorder, perhaps in cluster B. Right? The other way to kind of restate that is if you were to rewatch the episode like tonight, like it's a Friday, so you guys probably have nothing better to do, and specifically look for those signs and symptoms. Would you overturn anything? Right? It's a hypothetical. Won't do that. All right. So again, that's where we'll kind of leave the character of Gina. Just a quick tangent. Does her behavior remind you of anyone in fiction, literature? No. Manipulative, cunning. Plays on it's not to say that she plays on the ego of Martin, because Martin's prior to the suicide attempt, maybe playing on the ego of her significant other to reach her own goals. Literature.
Lady Macbeth.
It's Lady Macbeth. Yeah. And if we have time, we're going to spend about 30 minutes discussing the suicide, but we have time, we'll kind of make sense of the relevance and the allusion to Shakespeare's Macbeth here. Right? But before we do that, any other characters you want to discuss?
I'm talking about George.
We could always talk about George. What's up with George?
Well, the one thing I picked up on is, I guess, the power of words. And so when him and Elaine went to go see the psychic, and they weren't able to sort of get the complete story of why they shouldn't go to the islands, and he was just like over obsessing with, the reasoning. And even after when they saw them, when he saw her at the hospital, and he sort of like couldn't get the final answer. And so I think that just teaches us to be very mindful of like how we phrase things and say things, because someone could very well like formulate their whole life around it, kind of thing.
Yeah. Yeah, and in this case, I think it resonates even more because, and correct me if I'm wrong, it isn't necessarily what the psychic says. It's that it's what she doesn't say. She doesn't complete the sentence. So it's even beyond this little thing she may have said. It's the little thing that she left off the sentence, her not completing the sentence, that results in these intrusive thoughts that then we could clearly see pretty much impact George's behavior. Right? So let's say George Costanza presents to you with these concerns in a clinical setting, and you get the HPI, which is the plot of the suicide. What questions resonate in your mind that you would not now like to ask George Costanza? And this has less to do with uncovering other signs or symptoms, diagnostic criteria that might rule in for a particular illness, but more part of the general type of approach to a patient who comes to you with apparent clinical distress due to, and then you could fill in the gap here, the recent situation at the psychic.
I want to know why he went to go see the psychic.
Okay, why did he go see the psychic?
Elaine just mentioned that she knew the psychic, and he said that he had felt that things were going on, and he had, been having feelings about things or dreams, that he had already kind of been connecting the dots. But so when the psychic got kind of placed on the table, he jumped for the opportunity.
Okay. And then off of that question and perhaps answer, what follow-up question maybe? The idea here would be to see if you could establish a recurrent pattern of behavior and enduring behavior. Because if somebody goes and sees a psychic once, and even if it causes them distress, in psychiatry, you're going to probably have to shrug your shoulders. Now, again, the level of distress could be even a one and done is clinically concerning. But more times than not, we allow people to behave the way they want to behave. When we see a recurrent pattern of behavior, whether it's going to see a psychic, or whether it's the obsessing about what people say or don't say, then as psychiatrists, I think we're a little bit more concerned. And we want to establish that pattern, and we want to see if the individual has insight as to how that pattern of behavior is adversely impacting them, right? Why do you think it's causing you clinically significant distress or impairment, right? And I think that's the line of questioning for George right now. One of the things I would want to ask him is, have you ever seen a psychic before? Had something like this ever happened to you before? Because if the answer is no, you could see that my line of questioning is going to be now far different than if that answer was yes. And if the answer is yes, yeah, doc, I've seen psychics for years. I probably want to know why, what's behind that, because it might be nothing, but it might be something. And remember, the patient's presenting to you for help. So the idea of, well, anything they tell me, I'm going to dismiss unconditional positive regard doesn't really play here. They're asking for help. You're the detective that has got to find out what it is and how it is that you can help them, right? And then finally, if you establish that pattern, we could begin to focus on, well, the actual reason they're presenting to you. And in this case, it would be those intrusive thoughts. And let's say all of that holds true. And we're at a point now where he says, yes, not only have I seen psychics before, but I've done other things before where I leave situations, doc, and I always kind of just perseverate on things. And my doing that has caused significant distress to my family. I've lost my job. Now we're on to something. And at this point, you could begin to develop a differential diagnosis as you're actually taking a psychiatric assessment. And if so, what illness might be at the top of your differential here?
Obsessive.
Yeah. Yeah, I'm wondering whether or not this is indicative of an obsessive compulsive or related disorder, and OCD would be at the top of my list. Right. But in terms of that line of questioning, there's no evidence of compulsions. George, have you ever cleaned excessively? No. Counted? Nope. Washed your hands? Nope. Well, how now, what does that do in terms of where OCD lies on your hierarchy?
But you don't have to have both, correct? You can have obsessions or compulsions.
That is
So
correct. So
it's still on the top of your differential, because if he's still having obsessions.
absolutely correct.
Okay.
George
Yeah.
might be part of that 20% that has only obsessions or only compulsions. So it's a trick question. Right. All right. So, and again, I don't know if George Costanza has OCD. I don't. I've watched 9 seasons of this group. I've watched 9 seasons of George Costanza. I'm still waiting for the spinoff. And I suggest that he probably does have OCD, but and I think this episode, the suicide, might support that. Any other observations with George Costanza? Anything else you want to talk about with this character? What have you established that his seeing a psychic is pathologic? What else might you consider? And by the way, disclosure, seeing a psychic is not pathological. But for this particular individual, we're going to build an HPI in past psychiatric history, maybe even developmental history, in which it is, just because we want to teach from this one particular scene. What might come across your mind now in terms of formulating a differential as to why a person like this has repetitively seen a psychic and sought an advice from a psychic?
Maybe like a specific phobia. So like in terms of flying, he's very concerned with the flight. And kind of, I guess you need more history from him in terms of what kind of things he goes to the psychic for, or the exact reasons he goes. If there's something that's recurrent or very that's a common denominator among all those visits, then maybe you could explore like a specific phobia to something, or just a general fear of, like, I don't know if there's I know we just had a phobia lecture yesterday, but if it fits into those 4 main categories. Yeah.
Mhm. So if in your differential is a specific phobia, we already mentioned obsessive compulsive disorder. It sounds like anxiety might be driving this character, right? Because both of those conditions were on some slide that you saw yesterday, both OCD as well as specific phobia. The other issue with this, if you see this habitual behavior, if this is a recurrent behavior, is the consideration that you're identifying someone that has an external locus of control, right? Individuals need to be told about what lies in their future, and implicit in that is the idea that they may not feel as though they are in control of their future. I mean, there are some people who go see a psychic for fun, walk out, and will look at you and say, I don't care what they said. This is the only person that's going to decide if I do that or do that. That's called an internal locus. Right. On the other hand, the complete opposite, of course, with the external locus, which is a risk factor for anxiety and depression. So there might be a connection between his motivation to go see a psychic in a general sense, and then the specific reasons he makes that appointment that day, whether it's a phobia, whether it's obsessive thoughts or intrusive thoughts, and connecting those anxiety states with that etiology is this idea of an external locus of control. George Costanza is not self-confident, right? I'm going to give you that for, again, 9 seasons of watching Seinfeld. He is not self-confident, and he does not have an internal locus of control. He doesn't believe that he ultimately has control over what happens to him. All right, we're 20 minutes past the hour, about 5 or 10 minutes left. Any other characters you want to discuss today? Elaine? What's going on with Elaine?
So she's just fasting the entire episode.
She is fasting.
And then tried not to eat, which she ends up eating. This coffee tape.
Many of us who have to fast usually slept.
But yeah, I think it was interesting to see, her only like storyline in the show. I mean, that episode just being that she's just like dying with this coffee, and then she just grabs it and eats it. But I thought I was, I'm not sure, I've never watched Seinfeld before, so I'm not sure what her like role is in the group or.
Oh, you'll get to know her. In the next 5 weeks, you'll be introduced to Elaine. As she is fasting, would any of her behaviors be of interest to a psychiatrist?
Yeah, towards the end when she was kind of like going crazy. Just-
So talk to me about going crazy. That's our field.
Possibly hallucinating, but I mean, it's unclear, because some of the things she said, it seems like they could be just now thoughts when she made the comment about the dog food. I think the way that she was saying it made you think maybe she was hallucinating, but I mean, she was hungry and she just brought up the other dog food, but I think by the end of it, she was,
This is on a shelf exam, and the question STEM asks, what is the single best answer for that would explain Elaine's hallucinations and bizarre behavior? What do you think's going on here?
Psychosis.
So you think she has a psychotic disorder? I can tell you that Elaine Bennis does not have an established psychotic disorder.
I think it stems from the fact that she hasn't eaten. There's a medical underlying.
Hypoglycemia.
Oh, like-
Right.
yeah.
So
Yeah.
when you take the idea and the presenting sign of psychosis and you attribute it to an underlying medical condition, what's the single best answer?
Delirium.
Delirium. Yeah, delirium and hypoglycemia can certainly be part of that, right? So when we see someone who is hallucinating, when we see someone who is confused, when we see someone who is disoriented, especially in the hospital, and that could be maybe as soon as 30 minutes from now. One of our objectives is to figure out why. Right? There's multiple causes. I heard hypoglycemia. There's dehydration and malnutrition, but it's this group's task to figure out why for all of the individual patients who we diagnose with delirium. Right. So, how best to go about this? Well, let's quickly pivot to the other female character in this episode and get back to Gina and her allusion to Lady Macbeth. Right. You're not going to have to know Shakespeare. If you don't, shame on you, but you don't have to know Shakespeare. I Heart Lady Macbeth is an acronym to remember all of the etiologies for delirium. So these two women characters are actually connected. Right. So Gina, quote unquote, behaves like Lady Macbeth. Etiologies for the condition that Elaine Bennis herself demonstrates, delirium. So we'll quickly run through this. We have about 5 minutes left. And then, of course, we'll reapply this more than a few times clinically on the service. I Heart Lady Macbeth. Number one, immunologic causes. Heart, acute coronary syndromes. Lady, LP. So again, think meningitis, think subarachnoid hemorrhage. A, arterial blood gas, think hypoxemia. God bless you. D, drugs, right? It could be prescribed anticholinergic. It could be illicit. It could be intoxication, withdrawal. So think drugs. Y stands for a condition called YAWS, Y-A-W-S, which is a spirocheting infection. So think YAWS. Of course, we're not going to screen for that. What we're going to screen for is syphilis and neurosyphilis. And if you think SIP, it's 2023, you've got to think HIV infection too. So those two are going to be combined. Macbeth, M, malignancy. A, ammonia level. So think hepatic encephalopathy. There are a few C's. Comprehensive metabolic panel or CMP. Complete blood count, CBC. And then the final C is ceruloplasmin. So think Wilson's disease, especially if your delirious patient is younger. B12 vitamin deficiency. So always think B12 and folic acid. B12, much higher yield. And if there's any history of alcohol use disorder, think B1 deficiency as well. Vitamin deficiency, think Wernicke's-Korsakoff syndrome. EEG. EEG could be confirmatory, so diffuse delta waves or background slowing. Very nonspecific, but supportive of your diagnosis of delirium. On the other hand, it could be diagnostic too. That is, Non-convulsive status is when an individual has status epilepticus with no motor component. Without that motor component, non-convulsive, the seizure manifests as delirium. So EEG. T stands for TSH, so think thyroid. T also stands for trauma. And then finally, there's a few H's. Hypertensive encephalopathy, right? Head CT or MRI, and then finally, heavy metal poisoning. Right? That really does cover all you need to know about the potential etiologies for your delirious patient. That condition, in this case, our delirious patient is Elaine Bennis. Right. Questions about the etiology of delirium? All right. Remember, I heard Lady Macbeth, and the next thing we'll do, probably as soon as today, is apply that acronym to each individual patient and get an idea of how, in fact, do you sift through all of these multiple etiologies for a particular patient case. And there's actually an algorithm how to do that. That'll obviously be at bedside. All right. We're going to log off this link and log back on to our other link for table rounds in about 2 minutes. See everybody there.